Welcome to the session, Disease Management, Race and Kidney Disease Research and Diagnosis. I am David Rodriguez, a member of the AAKP National Board of Directors and Executive Committee, a member of the AAKP Policy Committee, and an AAKP Ambassador, and a current transplant recipient with prior experience on in-center hemodialysis. I am involved with AAKP because it's one of the largest independent organizations in the United States that are dedicated to improving the lives and the long-term outcome of kidney patients through education, advocacy, patient engagement, and research, and the fostering of patient communities. And those are their cornerstones I bring back to the state of Texas. I represent AAKP on a series of national initiatives, including the Patient and Family Affairs Subcommittee of Scientific Registry of Transplant Recipients, and as a member of an AAKP Patient and Family Advisory Committee that have provided unique patient insights into the clinical trial designs for many of our industry partners that are investing in new treatments, biologics, diagnostics, and devices to improve patients' choice and outcomes, and change the tired status quo of kidney care. As an AAKP board member, I have also been honored to have been published in the Clinical Journal of American Society of Nephrologists for my Patient Voice article titled Kidney Disease Burden and Kidney Transplantation, a True Story. It is my great honor to welcome our speaker, Dr. Keith C. Norris, a member of the AAKP Medical Advisory Board and Professor of Medicine at UCLA Division of General Internal Medicine and Health Services Research. Dr. Norris' research interests focus on hypertension and chronic kidney disease with an emphasis on health disparities. It is my pleasure to turn it over to him to share his presentation.
AAKP 2021. It is a pleasure to be here with everyone and this being part of this amazing symposia. It is my pleasure to spend a little time just talking about the role of race in kidney disease research, diagnosis, a little bit about care, and to answer some questions that have been coming up over and over again, particularly over the last year and a half, since we've had a lot of issues related to racial injustice and more focus on health disparities. So one question I'm asked is, why do we measure items such as race and ethnicity or gender? And the main reason why we do, there are many reasons, but the main reason is to see if there are group differences that require our attention. So if we don't measure these items, we won't know if there are differences. So for kidney disease, we want to know, are there differences in kidney disease in a particular group? Because of that, we do not want to take a colorblind approach that I don't see color, because we all do see color and we see people as they are, and all of society does as well. And importantly, our laws, our policies, our practices not only see color, but they treat people differently because of it. This is data from the United States Renal Data System that shows the incidence of end-stage renal disease by race over a 16-year period. And importantly, you can see at the top that the incidence is much greater in individuals who are Black or African American. Fortunately, it's getting better, but there's still a major increase in the incidence rate for Black and African American persons compared to their peers. What we also see is that American Indian or Alaskan Natives, which were markedly elevated at about 800 per million in 2000, are now close to their Asian and white peers. Similarly, if we look at the data by Hispanic ethnicity, we see major differences with much higher rates of end-stage renal disease or end-stage kidney disease by Hispanic ethnicity, but we also see that there's been improvement over the last 16 years or so. So we collect data by race and ethnicity or by gender because it allows us to see where there may be differences. And if there are differences, it says, wow, we really need to put in emphasis or focus on doing something differently to make that difference go away. So, for race and ethnicity, the first thing we need to understand is, what are they? So, race is really a social interpretation of how an individual looks in a race conscious society. And that's what we are. And we can say we don't want to be, but even if as individuals we are not race conscious, our policies, our procedures, our practices are race conscious. So that's very important. So race is a socio-political construct that was developed to control power based on how people look. And for the United States and many other countries, that political construct and that ideology is what is termed white supremacy ideology. And many people have heard of that. That does not mean uh, a, a right wing group or fringe group. It's an ideology. And the ideology is that white race is better than all other races. And that ideology was used to justify and to maintain chattel slavery early in the founding of America, the genocide of Native American and American Indians, and the ongoing oppression of people of color. Equally as importantly, we need to understand that race is indirectly, not directly related to ancestry, and indirectly related to health, not directly related to health. And that's very important because as a research variable, that then means race itself is a poor indicator of biology. It's a poor indicator of genetics, but it is a strong indicator of how one is treated in society, which in most instances comes down to racism. Similarly, if we were looking at gender, we would be looking at exposure to sexism. So one way to summarize this is race is socially assigned. It's how society sees people and how it thinks of you. Sometimes we think about an individual determining, and many times we collect data based on how people self identify, but it really is how society looks at you and how society thinks of you. Equally as importantly, equally as important is despite the official status in government and the census and research, there's really only one race, the human race. So we've made these other races and broken it up into different races. All that's made up. There's really just one race. But although we've made it up, it's important because it influences how our society works. The Pan American Health Organization, a subsidiary or element of the World Health Organization, holds what would be considered scientifically accurate view that there is only a single human race, and they use the term ethnicity to characterize groups of people that have different socio-cultural characteristics, traditions, ancestry, language, nationality, religion, or other. By contrast, while race itself or ethnicity may not have an important impact on on health and therefore the health disparities, racism does. And racism is the system of structuring opportunity and assigning value based on race or based on ethnicity. And over time, racism has embedded race hierarchy into our laws, our policies, our practices. And previously, those were very overt and explicit. Now they're much more covert and less explicit, but they still exist. And by design, they unfairly disadvantage some groups and unfairly advantage other groups. But at the end of the day, it saps the strength of our entire society by wasting human resources, human capital, human potential. Commonly, racism, and Dr. Kamara Jones, who talks about this a lot and led the early initiative to make racism a public health issue through the American Public Health Association when she was president, she looks at racism in three major buckets per se: structural or institutionalized racism, personally mediated racism, and internalized racism. And we're going to focus on structural or institutionalized racism through most of this presentation. So while race is how society looks at you and thinks of you, racism is what society does to you based on how it sees you. And so that's a big difference, right? So it's how people look at you, and that's doesn't make a big difference unless that then has an impact on you. And so racism has an impact because it's what society does to you based on how it sees you. So frequently, we measure group differences to see if there are health implications because what society has done to a group. And if we see differences, we call those differences disparities. We then have to figure out, is that good or is that bad if a particular group has more of something or less of something? And then how and why did it get there? So again, race is how society sees and thinks of you. Racism is what it does to you based on how it sees you. And when we roll that up into the groups, we then are able to start understanding disparities. So when we think about, again, race and ethnicity in medicine, it's important to understand that these are complex population level social variables. And again, as I mentioned earlier, they are not directly related to biology or ancestry or any genetics. We think of it as if it is, but they are not. The research data on race ethnicity is critical for population level assessments. And we use that to inform public health and community messaging. So when we see that there are differences in kidney disease in a particular population, we do outreach and messaging to that community to talk about why it's important and what people should be doing to try to reduce or improve kidney disease in that community. We may use that information for screening. We may use that information for intervening and then monitoring progress. We need to see if disparities are getting better or worse over time. We may use it to create policy to see if we can improve these disparities. So that's the major use of race and ethnicity in medicine. However, what I frequently hear is, well, since race or ethnicity are related to biology and genetics, can't we use them to learn about individuals and even to put them in equations such as modifiers for glomerular filtration or risk factors for transplant and use that for clinical care? Again, importantly, they are related to health, they're related to biology, but they're not directly related. They are indirectly related. And so we really can't make that link from the group to the individual. Let's take a look at that. So one condition we know very well in nephrology is that there is a gene variant or gene polymorphism or gene allele, as is described here in this slide, that is associated with an increased risk for kidney disease. And that allele, the APOL1 high risk kidney disease allele, is linked to a variant or polymorphism that's thought to have evolved over time to protect people against sleeping sickness in certain parts of Africa. And what we then hear is, oh, see, this is a gene that is a race-associated, race-based gene. And I'm going to walk through why it's not. So if we see here on this slide, even if we look at ancestry, where somebody comes from, population ancestry, Nigeria has a high prevalence of the APOL1 high risk allele. But even within Nigeria, you can see the Igbo ethnic group has a high prevalence of 49%, But some of the other groups have a much lower prevalence, 14.5, 9.8, and even 2.1%. So even if we look at the APOL1 high risk allele and try to connect it to population ancestry, and we say, well, people who come from Nigeria, we can't say by looking at someone if they have a high risk or low risk for having that allele. The only way we know is to measure it. Now, if we say we have this information about people from West Africa, we cannot then say that refers equally to everybody who we look at in society and say is Black or African American. Because there are people from East Africa, there are people from South Africa, in the United States, and Australian Aborigine would be considered Black or African American. And so they are clearly not related from a population ancestry perspective to people in the area of Nigeria. And so now we're 2 steps away from saying race is related to the APOL1 gene. So APOL1 is not related to race. It is related to one's ancestors having grown up in an area where trypanosomiasis or sleeping sickness is highly prevalent. Why using race in research is important really came to the forefront with the COVID-19 pandemic. And shown on this slide is a cartoon of different people in a building and those at the higher level with a higher socioeconomic status doing well during the pandemic, and those at a lower level of socioeconomic status toward the bottom not doing as well. They're sick, they're being dragged out. And in this country, they're more likely to be people of color. And so one thing we see is that there are many groups that are at high risk. Nursing homes, correctional facilities, and racial ethnic minorities are 2 to 4 times more likely to have COVID-19 infection, hospitalization, or death. So that was important in understanding and sort of seeing how different groups can be affected during this acute pandemic and affected in relation to this disease condition. So what COVID helped teach a lot of people who weren't familiar about disparities and how disparities are made, COVID helped teach us exactly how disparities in health are made. So there's increased risk of exposure to the virus. There's a high chronic disease burden among certain populations and a lack of access to quality care. And those together lead to poor outcomes. And the factors that contribute to that are called structural racism. Those factors include residential segregation, underfunded school systems, poverty, discrimination, and that leads to all of those factors in the arrows below, and those lead to increased risk of COVID-19 complications. And what we heard early on was, oh, this is terrible, the system's broken. And it's important to understand the system is not broken. Dr. Don Berwick, the former director of CMS, the Center for Medicare and Medi-Cal Services, is commonly attributed with having said this, quote, "The systems are designed to achieve the results it gets." And I'm sure he's not the only person who said that, but in fact, every system is perfectly designed to achieve that. If we want different results, we need to redesign the systems that we have. This structural racism is sort of framed as the totality of ways in which societies foster racial discrimination through mutually reinforcing systems. Again, these may be housing, education, employment, healthcare, criminal justice. And then these systems end up distributing unequally wealth, employment, residential opportunities, exposure to toxic environment, substances, nutrition, psychosocial stresses, healthcare access, and healthcare quality. I just want to digress for one moment A lot of people feel uncomfortable when they hear structural racism and white supremacy and these systems going back to slavery, and they say, I wasn't there, it wasn't me. Why are you talking? Why are you making me feel bad? It's important to understand that this is an American problem and it requires an American solution. These systems contribute to chronic kidney disease and chronic kidney disease risk factors, such as high blood pressure and diabetes. Don't be afraid of these names. No one who, during this conference or Zooms that you may be on during the year, no one owned a slave or created structural racism or developed white supremacy ideology. No one should be held accountable for that. What we can be held accountable for is, do we continue to support these systems? Do we continue to support these ideologies and these narratives actively or even passively by doing nothing, saying, I don't want to get involved? Because not getting involved allows them to continue going forward just as they are. Or are we going to help to dismantle them? And as we said earlier, we need new systems. Are we going to help to make new systems? It's also important to understand it's not about your skin color, your identity. Many people of different racial ethnic groups work to dismantle racism. And many non-white individuals actively support and promote racism, white supremacy policies, and white supremacy narratives. So you can support structural racism with any identity, right? So that's the issue around structural racism is not limited to your personal identity. It is limited to the actions you take. These systems that influence our health are often called social determinants of health. And I think they're more accurately described by the term structural drivers of health. Because although they're very powerful, we don't want to give people the sense that they're predetermined and they can't be changed. So they can be changed, and they may not absolutely influence one's health outcomes, but they are very powerful. And again, once set in motion, they continue without an identifiable perpetrator. Very important. So that's why being passive and saying, I just don't want to get involved, then you've chosen to passively support structural racism. And these patterns then reinforce discriminatory beliefs, values, the redistribution of resources. But it's important to understand that these factors strongly influence self-reliance and personal choice. And we'll talk a little bit about that later as we wind up. Okay, we've sort of gone through racism, structural racism, but what does that really have to do with kidney health? So what I've outlined here is how these factors, institutionalized racism, biases, etc., can contribute to disparities in kidney disease, right? So we talked about communities of color being 2 to 4 times more likely to have complications from COVID. Well, those same communities are 1.5 to 3 times more likely to need dialysis or a kidney transplant. And so these biases, these institutionalized systems that are informed by racist beliefs, they lead to the lower underemployment that you see on the left-hand side of this slide, higher rates of poverty, higher rates of poor education, lower literacy, poor communication, and distrust. On the right-hand side, they also lead to residential segregation, overcrowding, poor hygiene, and that leads directly to increased COVID complications, but long-term, it can lead to kidney disease and more. All of these together lead to stress and maladaptive coping behaviors that may include substance abuse, that may include eating disorders, poor nutrition, and more. On the left-hand side, as you're looking at the slide, you see underinsured or being un or underinsured, having limited access to healthcare, also being problems that arise from having low levels of employment, particularly in a nation like ours that does not have a universal health system. On the right-hand side, we see where the residential segregation increases exposure to environmental toxins and infectious diseases. And all of these together contribute to higher levels of inflammation, higher levels of stress, higher levels of endothelial dysfunction, which can directly influence and impact the kidneys. They can directly contribute to hypertension, diabetes, and more. And together, when all these factors happen over a long period of time, we call that weathering, the wear and tear of these stresses over time. And we measure that through what's called allostatic load. And so we may do measurements of higher blood pressure, diabetes, inflammation, and all those together we call measures of allostatic load. And what do those do? They're associated with a reduction in our telomere length, which is sort of a marker of longevity. But importantly, it increases our risk of having kidney disease develop, our risk of having kidney disease progress, our risk of premature morbidity and mortality, and our risk of needing dialysis or transplantation. So yes, these issues around race and ethnicity are critical to disparities we see in kidney disease. So what does that mean for a patient? A patient's getting ready to come in to see their doctor. And what one has to understand is that each patient, and particularly patients with kidney disease, there's already stress. Person has kidney disease, they're on medication, they're wondering what's going to happen. And if you add to that stress from poverty, stress from discrimination, and more, it impacts what's called cognitive processing, how our brain thinks and how our brain allows us to address tasks at hand. And those tasks are important for how we function in life. What happens if a person who comes from a community that is under-resourced or marginalized, and they already have chronic kidney disease, they make it to their visit? While they're at their visit, and particularly once they go home, they're struggling with all of these factors: the cost of food and housing, the stress of whether or not I may need dialysis or transplant. I'm thinking about what happens if anything goes wrong while I'm trying to juggle all these balls. There's already distrust of the medical system. There's the impact of the accumulation of toxins in the body from kidney disease on memory, the impact of medications on memory, and the impact of fear and anxiety and apprehension on memory, right? So all these lead to this impact to remember. It impacts our cognitive functioning, and it also impacts our ability to implement tasks. Tasks such as remembering to do what the doctor recommended to tell a person to do. It's hard, you're juggling all these balls. And so which one gets dropped? When a person doesn't take their medication, it may be because they couldn't remember. It may be because for financial reasons, they prioritized rent or food or electricity or other things, elder care, over themselves. It's not that they're a bad person. They made a personal choice and they chose others in their family over themselves. And so we as providers have to remember that, and we have to work with our patients. We have to reinforce these messages, but we also have to be compassionate and meet them where they are. So in caring for our patients, it's important that as providers, and also for those of us who are supporting our patients, maybe as family members, and if we have the capacity as patients to remember what happens in that office visit. As providers, we need to remember that many of our patients, particularly racial ethnic minority patients, are patients who belong to a discriminated group. They are more likely to have limited income. They may not, but they're more likely to. They're more likely not to have the best insurance or the best educational opportunities, the best health care in their community. And so all these factors may impair their cognitive processing even more than other patients. They may have an even more adverse biologic profile from the weathering that occurs and the multimorbidities that they have. What those patients need, what many of our patients need, or as patients, what many of us want is high quality care, but we also want to be treated with respect. And as a provider, we want to treat our patients with respect. We need to remember to treat our patients with respect. Patients need our empathy, our compassion, our support. They also need to be given hope. What they do not need is our judgment. They do not need our ire. They do not need another lecture. So they need our support, and they need our compassion, and they need respect, and they need to be treated the way we would want to be treated. Tell your patients and your colleagues that you treat them like family, and then do it. And for our patients, that's what you should expect from your provider, to be treated like family. And in that instance, there's a good chance that at least your provider, your healthcare system is doing the best they can to give you the quality of care that you can get and that you deserve. So in summary, race belongs in medicine because it is an essential part of the social history in the United States, not because it approximates innate traits that we've been conditioned and taught to believe race or ethnicity represent. Race and ethnicity data are important for population level analyses and public health messaging, but it should not be used or thought of as a fixed biologic variable for clinical formulas, algorithms, or even how I, as an individual physician, will treat a patient because now I know their race, ethnicity. That does not give me any more information about that patient. What it does give me is, as part of the social history, I now know they belong to a group that has these social exposures. And based on what's going on, based on what I want to do, I can now inquire as to whether or not they individually have been affected by these social exposures, because I know the social exposures address or impact the group, but I don't know if it impacted that particular individual. So I can now inquire about that. Because race and ethnicity do not represent any known homogeneous health traits that are unique and distinct for every group, and or distinguishing every group member different from another group, we do not use it at an individual level. We saw earlier, even people in Nigeria, for this APOL1 gene that's at higher risk for kidney disease, it varies from 50% to 2% within different parts of Nigeria, no less all of Africa. So race and ethnicity are used to capture group level differences, but we do not use them at an individual level. It is racism, not race or ethnicity, that affects not only communities and resources, but the biology and the cognitive functioning of individuals, as well as they can impact health beliefs and behaviors and practices, because people now have to respond to these exposures, and those are all important ways in which groups respond and individuals may respond. And this is critical as we think about how we're going to understand and unravel the many factors that contribute to health disparities and the way forward, particularly for those of us in the field of nephrology. So I want to close with this quote. The truth is that there is nothing noble in being superior to somebody else. The only real nobility is in being superior to your former self. So I want to wish everybody here many days of being superior to your former self. I want to thank all my colleagues, my patients, my family who've supported me, who've informed me during my career in working in health disparities, and wish everybody a healthy, Symposia. Thank you for giving me an opportunity to share a few thoughts, and again, looking forward to an excellent symposium.
Thank you, Dr. Norris, for that insightful presentation. In close, I'd like to share an excerpt from AAKP President Richard Knight's Juneteenth statement. As a kidney community, we should take heart knowing that united together in purpose, we have the shared intelligence and capacities to drive many more innovations and save many more lives. To do this, we need more thoughtful patient engagement, which means the inclusion of even more minorities in research, clinical trials, and disease prevention and treatment education. Most importantly, we must be united in our resolve to end disparate care and to expand care choices for all kidney patients, because every kidney patient has the right to pursue their dreams and aspirations. Thank you again for joining us.